So anybody would like to tell me about what topics within vascular access did you all do?
Miss, so we did the AV fistula, or the intravenous fistula, the intravenous graft, and we didn't really went to and well we went through CVC, which is the central venous catheter, in class last week.
Okay, nice. And what did you all learn about the arteriovenous fistulas, the arteriovenous grafts, and the arteriovenous, well, that's just it, the arteriovenous grafts, fistulas, and the catheters? That's the bloodstream. Okay, so did you all get the chapter for this for vascular access? So the chapter for vascular access is
Chapter
anybody
12.
knows? Nice. Chapter 12, right? Access to the bloodstream. And there you will see all the different types of AV fistulas, AV grafts, and also the catheters. So anyone has any questions? We had here. Oh my God.
Miss, I just want to know if it's an essay type in this
Every
access.
exam does have essay type questions.
So why can't just be short answer question?
Because that is how it is, Miss Paula.
So what is which, let me see. So how are we going to do a fistula essay? You're putting everything together?
Nice. I like how you're thinking. Of course, that is how he's going to do a fistula essay, right? And as Miss Anne will have told you all, and I also for the last exam, I believe that the reason why we had so much passes, right, for this exam is because you all would have been doing, the ones who wasn't able to do essays would have been doing their stuff in points, right? So when coming to you're speaking about the fistula, you speak about how the fistula is created, the origin of the fistula. You understand how long the fistula takes to mature. Same thing with the graph, right? And same thing with the catheter, because it is the access overall, right? So you start by speaking about the origin of it, how it is created, right? You talk about when it will be able to use. I got an essay from someone, and I find like the essay was quite good. You understand? And I kind of see that that person read chapter 12, right? So when you talk about the different types of you talk about the different types of the fistula, the different types of grafts, so the catheter, right? Whatever the topic is, right? Whatever the question is, whatever the essay is to write. But when you're writing, you write about the origin, then you write about how long it takes to mature, or how in a fistula case is how long it takes to mature. In a graft case, yes, you could use it one time, right? In a catheter case is you know you can use it one time, right? So you talk about how long it will take before use, right? You talk about the different types that it has. And remember, the more that you write is the more points you get, right? You also write disadvantages and the advantages of it. You need to know that, right? Especially for catheters, you need to know the pros and cons of using catheters, right? You need to know the problems that you can encounter with fistulas, the problems that you could encounter with grafts, you know, that you could get aneurysms, you could get Steele syndrome, all these stuff. Everybody agree with me?
Yeah.
Yes, miss.
Yes, miss.
Now, oh, so any other questions? Miss Paula, is that it?
Yes, thank you.
Miss Santana, I see that you are here too, and I just want to give you a big congratulations for making that great jump.
Miss, I don't know what I got. Remember, I suspended.
Oh, I'm going to message you, your mark.
Because I suspended, miss.
I know why you're suspended. I know.
I know.
That's so funny.
Miss Sarah, message me on my own too now, please, thank. I
What
got
happened?
suspended too.
And don't send that out instantly, Mark. No,
No,
try
I
to get in
wouldn't say
trouble.
anything. No, I wouldn't say anything.
Miss, send my snap, please. I got suspended too.
I know you want to, let me I have to call Miss Anne and ask her to send me over the just now. Send me over the marks. Let me call her. Give me 1 minute. And I want to congratulate Mr. Donovan also on making a great jump in this exam. I'm not sure if everybody.
Good evening, everyone. Sorry for being late.
Okay, so I just came off the phone with Miss Anna, ma'am. She told me about suspended students and stuff like that. So yes, apparently some students' papers wasn't corrected, but if you can message me and I'll find out for you, sir.
Good evening, Miss. I'll message you, right?
Okay, no problem.
Okay.
Right. So anyone has any questions about this vascular access stuff? You all know I still do notes with you guys. So anybody want to tell me about fistulas? Seeing that nobody has any questions, I can ask you.
The AV fistula has grown as a vascular access of choice based on multiple studies that describe better outcomes of the AVF compared to other vascular types. Some of those improved outcomes include decreased mortality, hospitalization, mobility, and infection rates, and cost efficiency.
Nice. So Shania, are you reading from something that is your notes?
Huh?
No, you're reading from handout.
Yeah.
Okay, I understand.
I didn't make any like personal notes as yet. I just highlighted like the key points in the handout.
Nice. So
So that
yes,
was reading from.
that's what you did. Nice. So when they ask, let's say they get a question, define what is a fistula, right? An AV fistula, give all details about an AV fistula. So we know that a fistula is an abnormal opening between two parts, right? But AV fistula is different from just fistula, right?
Yes. Miss, could I take a shot on what is the difference between a normal fistula and an AV fistula?
Okay, no problem.
Well, as you said, fistula is an abnormal opening between two parts, but an
Yes,
AV fistula is an opening from the artery and connecting to a major vein in your body, creating a fistula.
nice.
Am I correct?
Yes, you are. Yes, you are correct.
I just said that out of my head, knowing of AV fistula, intravenous fistula meaning a artery, and venous meaning vein.
Nice. Okay, so I can tell you all what I think about AV fistulas, right?
Yes, miss.
A fistula is native or autogenous, made from the patient's own blood vessels with no man-made tissue or plastic. And the reason why I said this is because you know that the graft is made from bovine, right? Which is not your skin, right? So I define that fact first, that it is native or autogenous, meaning that it is made from your body parts, right? So a fistula is a native or autogenous, made from the patient's own blood vessels with no man-made tissue or plastic. Most often, a scar marks the anastomosis site. It may take 4 to 6 weeks for a fistula to become strong enough for large gauge needles. So it is best to create 1 well before hemodialysis is needed. As soon as the surgery is done, strong, fast arterial blood flow starts to enlarge the fistula and make it tougher. When all goes well, the arterialization leads to the fistula maturing. When we talk about the arterialization, we are speaking about due to the fact that the vein and the artery is connected, now the blood, it pushes harder, right? Because it's instead of just one flow, you have two flows coming together. And a fistula does literally be beating like a heartbeat. And it does be going psh, 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 psh. That's how it does sound on the inside, right? About a week after the surgery, patients can start to do exercises like squeezing a rubber ball or lifting light weights. Small randomized studies show that these tasks may help fistulas to mature more quickly. So normally when a patient does a fistula, you just see them squeezing even before they go to do the surgery, right through they just be squeezing a ball, like what we just call a stress ball. They just be squeezing that to try to build the vein and the arteries so it will get bigger, so that therefore, it could get a bigger pump. And the more blood your fistula able to push, the better for you. You understand? The more mature and the faster that your fistula mature, which means grow, is the better for you, because therefore you have a better blood flow so that the machine will be able to pull this blood upon cannulation. The patient surgeon may or may not want the patient to do these types of exercises according to how well off the patient is. You understand? Or it always have these options, right? If possible, a first access should be placed close to the patient's wrist. Anyone knows the name of that fistula that is placed? What is the popular name that it goes by? Did you all know? By the patient's wrist? Anybody?
Miss, can you repeat? Can you repeat that?
I said, if possible, a first access, which is the first fistula to be created for someone, should be placed close to the patient's wrist. Say by your wrist, that is right between your hand and your right. So
Radiocephalic.
yes. What did you say? Radiocephalic or brachiocephalic?
Radio.
Nice. Yes. And there is a term for it. It's called the snuff box fistula. I don't know if Dr. Michael mentioned. Dr. Legion taught you all on Saturday. Did
Yeah.
Dr.
But
Legion?
Miss, that's in the book though. I read that in the chapter, the stuff
Yes.
box. Yeah.
The snuff box. And the reason why
I seen it on the handout.
okay, well, it's on the handout also, right? So yes, so the snuff box fistula, that radiocephalic, right, fistula. The reason why they rather put it there is because a fistula could spoil real easy. When you start to get some bad cannulation, you feel your whole fistula could clot up, right? So we'll talk about that later on. So the reason why they put it in that far part is because if it mess up, you could always use the upper part of the arm. You understand?
Yes, miss. They could keep going up.
Yes.
Only
If
past
it's spoiled,
certain levels.
you could use the upper part of the arm. And if the upper part of the arm spoiled, you could use the next hand.
Yeah.
Right. Good. So a common fistula type links the radial artery with the cephalic vein between the wrist and the elbow. This is a radiocephalic fistula. If needed later, a fistula can be placed higher on the arm. A failed access may damage lower arm vessels, so they may not be able to use for other accesses, right? So that means if you use the top of the arm first, the higher part of the arm, right? The upper part of the arm. And that fistula spoil or damage, you cannot use the lower part of the arm. So it's better to use the lower part of the arm first, right? So if that damage, you use the upper part of the arm. Everybody understand so far?
Yes.
I am not reading
Miss,
from
it come
any
like it
thing. Yes.
how the blood flow in
Yes. So
to
remember the
the
blood flowing from
fingers.
the upper part of your arm to go downwards to the bottom
Right.
part of your hand.
So
So
that
if
why
you
they
have a
use from
blockage to the
down
top,
to go up.
yes. Because if you have a blockage from the top, then you can't go down because you wouldn't really have a proper flow. And remember, you're cutting the vein and the
Circulation.
artery, no?
Yeah.
Yeah. Yeah. So that's how it does. That's how it goes. And when you do that snuff box, eventually, once your snuff box working properly, that whole bottom part of your arm does grow. Yes, it does has scar tissue, Mr. Grant. It does leave scar tissue after a while of cannulation. It does, some people that have it really bad, some people doesn't have it as bad. And with a fistula, even though it's a normal skin, after consistent cannulations, the skin does get tough on top there and it'll be looking shiny. You understand? Because it's consistent cannulation along that area. So it does get tough. Sometimes you chuck in somebody, you're cannulating them, and you have to use this extra force. And sometimes you're afraid to use the extra force because you don't want, with the force that you're going in, you don't want to go straight through. So that's why you just have to angle the needle at a certain way and stuff like that. We'll get into that later on when we do cannulation. Right? So anyone want to tell me what is the most common upper arm option? For the fistula.
The PTFE?
The what?
I can't pronounce it. The long, long word.
That is the material.
Now that one,
No, you're talking about grafts.
the
The
synthetic graft.
polyethylene
What?
thingy,
That.
miss.
That's for grafts.
Oh, okay.
Yeah.
Okay, so
Radiocephalic fistula.
nice. That is
Oh,
what I
just
want to hear.
I
Somebody now said it.
reading the wrong thing. Sorry.
No, it's
Transport
okay.
brachiobasilic.
Brachiocephalic. Right? That is the most common upper arm option. Right? So the person who said that they're reading the wrong thing, it's not that you're reading the wrong thing. You have the handout, but I am not reading from the handouts. I just try to make my notes so that you all could understand. You know, on as because I just want to read on off of a student level. So I just make notes on a student level. I have, I wouldn't talk in doctor terms like Dr. Michael and Dr. Legion because I doesn't want anybody to be confused. I just find when I finish talk, everybody should understand and be with me. And if you don't understand, you could always message me. A brachiocephalic, which is the brachial artery and the cephalic vein fistula, is the most common upper arm option. The cephalic vein lies along which side of the arm? Which side of the arm is the cephalic vein, sorry. So the cephalic vein it lies along the thumb side of the arm, right? So you put it on the thumb side of the arm. And it may be easy to see and feel. If these vessels will not work, the brachial artery and the basilic vein may be used. So therefore, we'll have a brachiobasilic. The basilic vein lies along the little finger side of the arm. So that's on the inner part. Right? It is not in the hand. Oh, yeah, this is in chapter 12 of the book. on page 98, there is the vessels for the creation of the AV fistula, right? Also in chapter 12, which is on page 90, and on page 98, you could see the different types of veins that is used to create the fistulas. I'm typing it here on the Zoom chat, right? Page 98 for the AV fistulas creation. So the basilic vein lies along the little finger side of the arm. So since this vein, it tends to be deep, right? It tends to be deep on the inner arm. It could be challenging to cannulate, right? So the surgeon lifts the vein, or they transpose the vessel to the outer part of the upper arm to do this, so that they can get access to that vein. You understand? So most likely they use the cephalic vein, but if they cannot get the cephalic vein, they use the basilic vein, right? So the cephalic vein is on the thumb side of the arm, and the basilic vein is on the little baby finger side of the arm. You understand? So if they cannot get the one on the thumb side, they use the one on the baby finger side, which is the basilic. So it's brachiocephalic and brachiobasilic, right? Everybody with me on that?
Yes, miss.
Nice.
Yes, miss.
Everybody understand? And everybody who understand, put up raise a hand in the chat. Everybody who understand, everybody who with me, just raise. Give me a raise of hands. Okay, so I have two people understand, Tiwana and Mr. Donovan. Okay.
It's like I never find
Okay, I see this. Yes, Bernadette, you could never find the hand.
Yes.
I don't even know which part the hand is. All I know is that you're able to raise your hand.
The hand is any
Under
little
reaction with the little hand.
reaction with the heart.
Oh, nice. So you just find the little hand. You see, look, I learned something today too. Right. So right. I have persons with me here on this. Right. So the surgeon may lift and transpose the vessel to the outer part of the upper arm. Nice, Bernadette. I saw you. Great. So how to notice if the patient has the brachiocephalic from the brachiobasilic? With the brachiobasilic, right, the surgeon does make a long cut or a series of smaller cuts in the upper inner arm, right? And if you see this, that is how you just know that they have a transposed flat brachiobasilic, right, versus the brachiocephalic fistula. So the brachiobasilic is on the inside of the arm, the brachiocephalic is on the outer side of the arm, right? Brachiobasilic is on the baby finger side, which is on the inner side of the hand. If you put out your two hands, your brachiocephalic, your brachiobasilic is on the baby side, the baby finger. So if you run your hands, or you take your right hand and you pass it up your left hand, right? From your baby finger come up, that is the inner side of your hand. And if you use your finger and you pass it up the thumb part, you will see that's where the cephalic, you'll get the cephalic vein, right? And we have the brachial artery. So they connect these two, right? So before fistula surgery, anybody could tell me what happens?
I believe they do a test and they do an ultrasound.
Nice. And what they call this test that they just do?
Allen
The
test.
Allen test.
Allen test.
Nice. Nice. And there's also something else that should be done. Something called vessel mapping.
Yeah, that.
Right? So before fistula surgery, patients should have vessel mapping done. Right? And this painless ultrasound test may improve the chance that a surgeon will find vessels that will work for the fistula. So that is how you'll know which vessel is best to be used for the AV fistula. At the time of surgery, the chosen blood vessel sites are marked on the skin. An incision is made. So this is how they create the fistula, right? So we was just talking a little bit about we talk about two types of fistula, you understand, and we're talking about how the fistulas are actually made now, right? So at the time of surgery, the chosen blood vessel sites are marked on the skin, and an incision is made in the skin over the blood vessels that will be used. Then the vessels are sewn together. So anyone could tell me the name of that mark, that cut that they make? What is the name of that cut that they make to join the vein and the artery? Anybody?
That's the one known as end to end.
No, that no. Yes, but it's not just any. What is the name of it? That is the type of it, right? That is the type of what I am asking for, right? What
That's
is
just on the
what
top
I'm
of my
asking?
head. I don't have the I now live in work, so I don't have the
Yes,
handout with me.
Mr. Donovan and Ms. Tuse, I understand, but yes, it is the AVF connection, but what I call this AVF connection? We have 34 people. Miss Davidson, are you online? Can you answer me? Destiny?
Venus.
And not anatomical.
No, an arteriovenous.
No.
Not that one.
So nobody knows what is the name of the incision? Yes. Somebody, look, Mr. Nicholas. Yes, thank you, Mr. Lachman. And anastomosis. That is the name of it, right? So the surgeon will make an anastomosis. And I want you all to get used to using these words, because when you name things properly, you tend to get marks for it. So it's not just they make a connection and your connection is ending, right? Yes, it have but the connection has a name. So that's why you hear me asking you all these things, and I want you all to think, pressure yourself a little bit, pressure your brain, right? A little bit. So an incision is made in the skin. This incision is called an anastomosis, right? And whether the surgeon will make an anastomosis that uses the ends or sides of the vessel, it depends on the patient. So there are several different types of anastomosis. To be clear, there are 4 different types of anastomosis, right? Can anyone tell me the 4 different types? Or you all can just tell me one by one type of the anastomosis if you can't remember the 4. So let's take a go at it. Nice. I have, and someone said end to end. I see it. Mr. Donovan, end to end. I need another one. That is, I think it is all.
Side of artery to end of vein.
Nice. Side to side, which is the side of the artery to this. Somebody said side to side. And some said side of artery to end of vein. Okay. End of side of artery to, nice. Okay. So we have end to end, side to side to end, and one more.
End of vein to side of artery.
End to side. Right. Nice. So that is how I would like it. We have is basically back to front for that last one, right? So we have end to side, and end to side is the end of the vein to the side of the artery. You all can take it down as a note, right? So we have end to side. This is the different types of anastomosis, right? Which is the incision that is made to join the vein and the artery. So we have end to side, which is the side of the artery to the end of the vein, well, the end of the vein to the side of the artery. So end to side. Then we have side to end, which is the side of the vein to the end of the artery. Right? You all understand that? Did I say it correct or I said something wrong?
No, miss. Well, at
Right.
least I think I write it down correct.
Yes. So we have N, I'm going to go it over again. We have N to side, which is the end of the vein to the side of the artery. Then we have side to end, which is the side of the vein to the end of the artery. Then we have side to side, which is the side of the artery to the side of the vein. And then we have end to end, which is the end of the artery to the end of the vein. Everybody got that? That is the 4 types of anastomosis.
Yes, miss.
Okay, so a trill, bruit, and the pulse are always to validate or to prove that a new fistula is patent or that it is open or that it is working, right? So after the incision is closed, or after the anastomosis is closed up, there should be a trill which is a vibration or a buzz. You just feel it vibrating. When you have a new fistula, you just feel it vibrating. That's the blood running through, right? So it have a trill or a buzz over the new fistula. The trill is the strongest at the anastomosis, and it gets softer along the length of the fistula. Right? So the reason why the trill will be at the strongest at the anastomosis is because that is where they made the incision, right? And the fistula needs to mature, it needs to grow, right? And it is never recommended to go cannulating anyone on the anastomosis, because remember, this is where the cut was, and you could damage the person's fistula, right? By doing this. And anytime they go out to the dialysis center and they're seeing them cannulating the patient near to the and I think it's 4 inches away from the anastomosis. You're supposed to cannulate, right?
Miss,
4 inches.
I don't think it's not 4 in, well, technically 4 fingers with.
Right, that's 4 inches. Well, my finger them big.
Okay.
So yeah, 4 finger width. Yes, 4 finger width is like around 4 inches. We don't just say 4 inches, right? Yeah, 4 finger width. If you really can't get it, you use 3 finger widths, right? But you're not supposed to go closer than that. It have people, I have seen big old technicians cannulating people right over the anastomosis, and the fistula start to mature and swell really big, and then the patient start to get problems, and they start to say, I can't move my hand. It have a lady, she got cannulated several times on the anastomosis, and now she can't even hold a cup to drink something with the hand, because it got damaged, right? So yes, 4 finger lengths, right? So I have is the 3. I mentioned 3 things that you should be able to have when you finish the anastomosis, right? So you need to have a trill, a bruit, and a pulse, right? So the things are the trill. The trill is a vibration or a buzz over the new fistula. The trill is strongest at the anastomosis and it gets softer along the length of the fistula. You should be able to feel a pulse that is like a heartbeat when you place your fingers lightly on the fistula. So it's on your finger. When you place your finger on the fistula, and even if you watch it, you'll see the fistula is like it jumping. It right? So it looks like it jumping. Call it the pulse of the fistula. Right? So with your fingers will rise and fall slightly with each beat. With a stethoscope, you should be able to hear a bruit. And this is one practice that from the beginning, since I was a trainee until this day, I can cannulate without even listening to a fistula because I am really good at cannulation, right? And I can cannulate without listening, but up to this day, I know that it is see, hear, and feel, right? So you listen with your stethoscope, and that's when you just hear the psh, 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 and that is literally how a fistula does song on the inside. And I like when students come across the dialysis center, and I'm going to, before I cannulate and I am using my stethoscope, I'll tell them, come and hear how the fistula does song, right? So you see, you hear, and you feel. You observe your sight, right? You look at the pulse, you put your finger, you feel for the pulse, you feel for the trill, for that vibration, you understand? And then you take a stethoscope and you put it on the patient fistula so you can hear it. And you will hear at the big body anastomosis, it is louder, and as you go higher up, it gets softer. And that does even make you a better person at cannulation because when you're able to hear where the bruit is the strongest, right? You know it's there to cannulate because sometimes even though the patient, your finger lengths away from the anastomosis, the patient sometimes just have a dip in the fistula. You understand? It have the parts where it's right over the anastom, right the forefinger length, and you're not hearing it, and a little higher up you hear it better, saying, well, okay, you're not cannulating, that's what you're cannulating higher up, because at that point, it could have a stenosis or something like that in the fistula. New technicians are not to cannulate new fistulas, right? So only the nurse or the head technicians are to cannulate new fistulas. So we have spoke about vessel mapping and the surgery. We spoke about the creation of the fistula. We spoke about the anastomosis, right? We spoke about what you're supposed to feel to know that the fistula is working after the creation of the fistula, right? Now, let us speak a little bit about assessing the fistula's maturity. So the patient has the new fistula in, and how long should you wait before cannulating this fistula? Nice. So it have the rule of sixes, right? So it have the rule of sixes. I think it's 6 weeks, 6 weeks, 6 millimeters, but I can find it. I don't know if it is in the handout.
Miss,
Yes.
sorry about that. A greater than 6 millimeters in diameter, less than 6 millimeters below skin, less than 6 centimeters of vein line for cannulation, have a blood flow greater than 6 milliliter per minute, and be evaluated for non-maturity at 6 weeks after surgery.
Right, so that's the rule of sixes.
Yeah.
Nice. So yes, it have the rule of sixes. And also as a new dialysis technician, you will not be putting needles into new fistulas, right? New staff should never cannulate brand new fistulas because they are delicate and they require an expert, right? So the nurse will need to check all the new fistulas each treatment to see if they are maturing. You could watch for signs and you could even ask the nurse and all because I just always say this is how you just build experience. You can't know if a fistula maturing if you just stand up and watching the nurse. Right? So even though it's a new fistula, be pushy. I like to say be pushy because I was a pushy person. I was always a pushy person and I will always be a pushy person because I'm always keen to learn. So I can cannulate a new fistula, but I don't because I just not doing it. And it have the nurse there. I done it already when our head technician was not there, and I got through. I did it with the nurse, but the nurse allowed me to due to the fact that I can cannulate really good, right? But the only how you will learn is if you push yourself. So when you take a tell the nurse, hey, I want to be able to feel this fistula, the maturation of the fistula, and you will know, right, how to and you'll learn eventually how to cannulate new fistulas. Right? So all the patients with new fistulas should have a post-operation visit with the surgeon 4 to 6 weeks after the fistula is created. And that is when now the surgeon that created fistula, they are the ones who have to give you the okay to go ahead and use your fistula for dialyzing. Right? If the surgeon and to give you and give the patient that are okay to use the fistula for dialysis, they cannot use the fistula, and not even the head technician or the nurse could say, yeah, your fistula feeling good, man. Come here, cannulate it because they could spoil it, you understand? And they didn't get consent from the surgeon or the doctor to cannulate your fistula. Right? Everybody understand so far?
Yes, miss.
Right. I'm glad that one person understands so far out of 34 people.
Yes.
Yes,
Miss,
miss.
I do understand.
Joanna, you don't understand?
I say I do understand.
Oh, I don't
Miss,
think
can
you
I
get
call
a
you
whole of
after
career
class?
over.
No, I answer, but my mic was on mute.
Yes. Nice.
Excuse me, miss.
Yes.
Can I call you after class?
Sure, no problem.
Okay, no problem.
I have my notes. I can send you some pictures. Now, after how to say it, after I did class at the IME, right? And I started to work on stuff like this. I was able to buy textbooks. Now, I didn't buy just the IME dialysis textbook. I have like 3 different dialysis textbooks that I use, and I put all my notes. That's how I put all my notes together, right? Because I always wanted to be this perfect technician. I mean, nobody is perfect, right? But very rare I make mistakes with my job because it's people life you're playing with and you can't afford to make mistake with people life, right? So that's why sometimes when I'm calling notes, my notes is not from Dr. Michaels. It will be the same because it is joined, you understand, with Dr. Michaels' notes, but it's just for a better understanding and a better breakdown of the notes. But it's the same thing. Everybody agree? Have I told you all anything different from what Dr. Legion or Dr. Michael taught you all on Saturday?
No, miss.
No.
Am I confusing you all?
No,
No,
miss.
miss.
No.
Great. I do not want you all to be confused at all because vascular access is a tricky thing, right? Good. So, So what basically what the nurse will look for after the surgery, they will look for a hand that looks the same as it did before the surgery. So that will tell them if the fistula is maturing or not. You understand? So if your hand, the hand still looking flat, like nothing ain't going on, you understand? That shows that the fistula is not maturing. Another thing that they look for, if the skin over the fistula that is all one color and it looks like the skin around it, right? If it's blue or pale, the skin, this if the skin around the fistula is looking blue or pale, it could mean that the patient have something called Steele syndrome, right? So anybody could tell me
I have
what Steele
something
syndrome is
I have
basically.
something written about that,
Tell
Miss.
me,
I
I'm
have
listening.
it also known as DASS, dialysis access seal syndrome, is a
Nice.
condition that can occur when a person has an arteriovenous fistula or graft placed for hemodialysis. It happens when too much blood is diverted or stolen from the distal part of a limb into the dialysis access, leading to poor blood flow to the hands or fingers.
Nice. And that's like a perfect answer. And that's like a perfect definition for Steele syndrome. Because the reason why they call it Steele syndrome is because it does exactly that. It steals the blood away from the hand, right? Teeth, like teeth, right? It thiefens the blood. It does exactly that. It steals syndrome. It steals the blood away from the hand. So a fistula with steal syndrome, right, is a fistula that steals too much, right? So it steals too much blood away from the hand. So the patient will have like a lack of movement in the hand because they're not getting that proper blood flow. And Tiwana, you can feel free to share your definition with the others. Anybody, I don't know if you want to share it. If you want to share it in the group, Tiwana,
Yeah, I
right?
can send it.
Nice, so that the others can get it, right? And Tiwana has the perfect definition. Like I went looking up that girl.
Miss, because I highlighted it from the book
Yes,
and the handout also had it, so I was like, this probably important.
yes,
So I
yes.
got the definition one time.
Yes, it is actually important. So yes, that's exactly what Steele syndrome does. It steals the blood, right? So another thing that you look for is no bruising or swelling of the skin over the access, right? Once it have bruising or swelling over the access, that means something wrong, right? You look for no redness or drainage. Now, we had a patient. I don't know up to this day, but I suspect that he went and chuck his own hand, right? Because he came in with the fistula bleeding. As in, like if he got cannulated, you understand? And he said, because his fistula was giving trouble, he had an aneurysm, right? And that morning he came into dialysis with his fistula freshly, it was a fresh cannulation. And he was like, no, my fistula just started to bleed just like that. And we did not cannulate him. You understand? And the week after, his fistula was spoiled, right? Because he went chucking his own fistula because it was giving problems apparently, and he was trying to prove the point that his fistula was working. The things people just do, right? Nice. So the trail will grow stronger as the fistula matures. The pulse, which is a slight beating that makes your fingers raise, right? The pulse and all this gets stronger, right? And the fistula vessel itself will continue to grow, where you should be able to see it more and more. So anybody have any questions about fistulas again?
No,
I
miss.
realize. I want to read a small note on Steele syndrome also, right? A fistula or a graft can steal too much blood from the hand. So it does not get enough oxygen and the tissue dies. Patients with Steele syndrome have hand pain that can range from minor to severe. In most patients, this pain lessens over time as new blood vessels grow and bring blood to the area, called collateral circulation. Okay, I don't want to go into the complications of fistulas and grafts as yet, right? But yes. So I believe that was all about the creation of fistulas. Yes. I do not want to go into cannulation quite yet either.
A quick
Because I
question.
don't want to get you all confused. I want you all to know about fistulas, the creation, and what happens after the creation, the anastomosis sites, right?
Quick question, Sarah.
Yeah.
Excuse. Would we be labeling any diagrams for this
No,
exam? Okay.
I don't know, but no. I just say no, but it's not a matter of labeling the diagram. You understand? But you have to know. You have to know.
Where it is
So
and
wait, my battery going and dead on the top of my laptop. Wait. Harry, the one meeting for L. Oh my God. Okay. Didn't even realize that my laptop wasn't plugged in. You're seeing this low battery sign here. Okay, nice. Okay. Yes, so you need to know the different types of fistulas, right? How it is created, right? The different types of anastomosis. So when you could write all these things separate. So therefore, when you have to write your essay, put everything together.
okay.
So it's all about AV fistulas, right? And then when talking about AV grafts, you're on page 101. Page 100 and page, let me I'll type in it here. Okay, this is page 98 for the AV fistula creation, the different times, right? And page 100 and page 101 is grafts, right? That's where you all can get the different types of grafts, right? And as you all can see, you see the brachial artery cephalic vein, right? The ulnar artery, the brachial vein. So it's the different types of grafts, right? So we have everybody. You are on page 101, but I just reading from page 101, right? Just for
Miss,
the time and the
someone is
name.
in the waiting room.
Okay, I'm going to see.
All right.
Oh, that's Kadira. Okay, I admitted her. It's joining. Yes, so on page 101, there are four that you have seen four different arms, right? Where
I think some people have it on different pages.
oh, okay. Well, I have the 10th edition, right? So I know the 9th edition probably different for the ones who have the 9th edition, but I have the 10th edition. Review of hemodialysis for nurses and dialysis personnel by Miss Judith D. Kallenbach. Right? That's the page. So it have the four different arms on that page, and there are that is the different types of grafts. So we have the straight forearm PTFE graft. And what does PTFE mean? And what is PTFE? That is the type of
Vital
material. That is
material.
nice. So someone says try page 114, 114. I haven't. Okay. Miss Kadira, hi, good evening. I see that you have just joined.
Good evening. Sorry for being late.
No, it's okay, but we have already spoken about AV fistulas, right? So someone can share the note with you. And now we are speaking about grafts, right? So
Okay.
page 101 is where it will have the four arms. Some persons do not have it on page 101, they have it on page 114. So it have the different types of grafts, right? Where you can see it have A, which is the straight forearm PTFE graft, and PTFE means polytetrafluoroethylene. And I'll say that word again. Polytetrafluoroethylene graft, right? So the polytetrafluoroethylene grafts in the arm, right? The different types of PTFE grafts. And it will be really nice that you guys learn that word polytetrafluoroethylene. And the reason why I am saying it like that is because I really want you all to learn the word. And it is spelled POLYTETRAFLUOROETHYLENE. Polytetrafluoroethylene graft in the arm, right? So this is the fake fistula, I like to call it. You know, it always have a want to be, right? So when you do not have big enough veins and arteries, I'll put it like that, they use what? Somebody tell me the name of it.
Polytetrafluoroethylene.
Yes. Yes,
Miss,
Mr.
that
Dia.
was
Yes.
frightening so much that we learned that. That is the first thing we learn.
Yeah.
Yeah, that was real big. When I see it first time, I was like, wow, what kind of big word is this? Yes. So I feel I'm not going to. So somebody could tell me what the four different types. So you can say, well, you can say PTFE, but if you want to say poly, you know the whole word, you can say it.
They have the long arm in PTFE graph, they have the curved upper arm, and they have the loop upper arm PTFE graph. These are the straight arm.
Right. Yeah, so we have the straight forearm. That's A. B is the loop forearm. C is the curved upper arm. And D is the looped upper arm. Now, I hate that loop upper arm graph. That is the worst graph ever. We have a patient, we have two patients with the loop upper arm graph. I hate to calculate it as we run. It's really it's because it does now you just have a flow and you just have a map showing the flow of it. But no, graph is it's hard. The material in a graph is hard, and what makes me don't like to cannulate the graph, right, by us is because the two patients with graph, the hand real big. They are big bodied persons, right? And the hand just real thick, and it does be plenty work. You understand? Now we had a patient. She had one of the straight forearm graph. I used to calculate it normal. I also had a patient with the curved upper arm graph, and I used to cannulate her. But you see that those two patients with that loop upper arm, and due to the fact that they are really big bodied persons, it is tough to cannulate, and I am not going to put my job at risk whether I can do it or not. But I can do it. I did do it before, and I just didn't like the whole feel of it. So I was like, nope, I'm not doing this. And I leave it to the other text. Like, I let it go through, right? So if I don't like something, I don't do it, right? But it is a tough graph. It is graph on the whole is tougher than fistulas to cannulate, right? For my exam, the nurse find that my cannulation was good with the fistula, so she put me to cannulate a graph, and I find it was unfair because grafts also bleed more than fistulas. Because remember, this is not your body that you're using. You understand? It is a out of your body thing. You understand? So it does bleed more when you're taking out your needles, and to me everything just offered graft because it just fake and it's tough. You understand? It just be this big tough skin. You already had to go through the patient's skin being tough, right? Because remember, you just have that growth after a while of only cannulating. So the patient's skin already tough to go through. And when you go through the patient's skin, it's like you have a second skin to go through, because the graph is the PTFE that you have to go into. You understand? So it's like two different skins that you have to cannulate when cannulating a graph. You understand? And then the flow of the graph, it depends. So sometimes you have to cannulate antegrade, retrograde, which is the needle facing the anastomosis, and then the venous needle facing towards the venous. You understand? So yes, that is why I do not like to cannulate that looped upper arm PTFE graph, because it is more tough. It's more tough to candidate than the straight upper arm graph, right? Or the curved upper arm graph, sorry. So how grafts for hemodialysis accesses are made? Grafts, what are grafts? Grafts may be straight, curved, or looped. Some designs provide a larger surface area for the needle insertion. And yes, that is also another reason why I don't like to cannulate that curved upper arm graph, right? A forearm loop graph is preferred because it provides the largest surface area for needle insertion. Grafts are tubes made of biologic, right? Meaning from a living creature or bioengineered synthetic materials, right? So some grafts, which they doesn't really do this, but just for knowledge purposes, some grafts may be made from a vein from the patient's leg. Some are from human vessels donated after a donor's death, right? Some is bovine, which is cow arteries and veins, can be used for grafts after they treat it to remove the proteins that would cause a human body to reject them, right? And some that's in early times I using grafts that would I use these bovine. You all got Dr. Lejean told us anything about bovine grafts that they used to use long time?
No, miss.
Yes. So before they started the PTFE grafts, they used to use bovine grafts, right? Which is cow arteries and veins that they used to treat because the human body used to reject. Remember, anything that is not yours, your body could reject it, right? And you could that's why you get infections and stuff like this, right? So in early times, they used to use bovine grafts, but it had a high infection rate and a high aneurysm rate. So they don't use bovine grafts anymore. It is off the market, right? Then they they had bioengineered materials, right? And that is how they had the PTFE. So now the polytetrafluoroethylene grafts are used due to it is bioengineered materials. So with the AV fistula, now that is the difference between the AV fistula and the graft, right? So for the AV fistula, I told you all, I'm looking back here. I can't find it. That okay, well, I told you all that you know the AV fistula, it is native or autogenous. So the difference with the AV fistula, it is made from your vein and your artery, so therefore it is native or autogenous. With the grafts are bioengineered materials, right? Also known as polytetrafluoroethylene or PTFE. I have that. Right. An AV graft is also a permanent or venous access. Right? To make a graft, a surgeon connects an artery to a vein with a piece of artificial or biologic blood vessel. And in this case, it is artificial, but you could still mention that artificial or biologic, meaning from a living source, blood vessel. Everybody got that? An AV graft is a permanent or venous access. To make a graft, a surgeon connects an artery to a vein with a piece of artificial, which is man-made, or biologic, which is from a living source, blood vessel. Right? So they are bioengineered materials, which is PTFE, that is used now to create grafts. How a graft placed? A graft is inserted under the skin through a tunnel made by a surgeon that looks like a bridge between an artery and a vein. A fistula has one anastomosis where the vein connects to the artery, right? And I want you all to take note of this. So due to the fact that the fistulas are native or it is made with your vein and your artery, only one anastomosis is made, right? But a graft has two anastomoses. And what is the anastomosis? What is the anastomosis? Nobody hearing me?
Yes, miss. I'm looking for the answer just now, eh?
Could hear I wasn't here, but everybody else was here when we
End
were
to
talking just
end,
now.
end to side.
Right, the anastomosis is the incision made to join the artery and the vein. Right? So the incision made to join the artery and the vein is the anastomosis. Right? So with a AV fistula, it has one anastomosis. With a graft, it has two anastomosis. There is the arterial anastomosis, where the graft connects to the patient's artery, and there is the venous anastomosis, where the graft connects to the patient's vein. Because remember, you're not able to join the vein to the artery. This is why you need the graft to connect it. Right? Everybody understand that?
Yes, miss.
Yes, miss.
Yes, miss.
Yeah.
Nice. Unlike a fistula, grafts do not need to mature, but they do need to heal. Right? So we have talked about the different types. So when writing an essay about grafts, you can write about you start by writing what a graft is, what it is made up out of, you understand, and how the grafts are placed. Right? Then you talk about the different types of graft, which is the looped graft in the forearm, the straight graft in the forearm, the straight graft in the upper arm, and the loop graft in the, or you all also know that would have a loop graft that take place in the thigh. Do you all know that?
Yes, miss.
Yes, miss.
Yes, and that we had a patient. I don't know if I told you all about my patient that had the bone disease. And she ended up with
Yeah, I
like three
remember.
different types of graft, right? Because one hand, the first hand break with the fistula, right? And then they put a graft in the next hand, and that hand break, and then they put a graft in her leg, and then she did, right? Because she was just getting break up because of the parathyroid, the hyperparathyroidism, and the bone disease, and these kind of stuff, right?
Miss?
The one in the thigh is thigh loop grafts.
Yeah, a looped graft in the thigh, yes. A looped graft in the thigh. So we have those 4 different types of graft, and well, could say 5 because you're adding the thigh graft, right? So you have the 4 different hand, which is grafts in the arm, right? And then you have the thigh, the looped graft in the thigh also.
Excuse me, miss.
Yes?
I heard that like people that doing dialysis bones tends to get weakened. Hence the
Yes.
reason why their bones be brittle and get like brittle bones then.
Yes, that's what secondary hyperparathyroidism. Remember when we did that whole stuff about vitamin D, and when anybody not able to absorb vitamin D, well, it's not that they're not able to absorb vitamin D, it's that it wouldn't be able to absorb calcium due to the fact that the kidneys is damaged, and the conversion from vitamin D2 to D3 is messed up, right? So then the patient not able to absorb calcium, and with the patient not being able to absorb calcium, that's when the message goes to the brain, and the brain now send the message to the hypothalamus, and then to the parathyroid hormone, and the parathyroid stimulating hormone, and then the parathyroid stimulating hormone stimulates the parathyroid gland, and then it's you start to get parathyroid hormone in your body, and it tells the osteoblast and osteoclast to start digging calcium from the bones, because the body is not getting any calcium, right? So that is how the bones will get brittle, because the body not able to get the calcium due to the fact that the conversion of D2 to D3 is decreased. So yes, that's how they get the osteomalacia and whatnot. You remember that? Everybody remember that?
Yeah, miss.
Yes, miss. Yes,
Yeah.
miss.
But I said to explain
Yes,
that
miss.
so nobody can explain it.
Yes, miss.
Yes. So that's why there's not for the brittle bones and the bones just start breaking up. Yes. So what else about grafts? Unlike a fistula, grafts do not need to mature, but they do need to heal, right? And cannulation can start as soon as the swelling has gone down. When you cannulate a graft, you do not use a tourniquet. Why you do not use a tourniquet when you have to cannulate a graft?
Because it can easily damage the material the graft is made of.
Yes, but not only that, but because a graft is not that's not your vessels, it's fake. You understand? So it have the flow going on within there. So you don't need a tourniquet. You use a tourniquet on a fistula because that is you want to get an extra punch, right? But with a graft, is fake material. So you don't need to use a tourniquet to tie to get that punch because you could actually just feel the graft, right? And the graft material it will not expand under pressure. So to find which way that the blood flows in the graft, you have to feel the entire length of the graft, right? And you could press the center of the graft with your finger and you'll feel for the pulse or the thrill in your graft. So it is always the pulse and the thrill is always more present in the arterial end and it gets weaker in the venous end. So you can read page 100, right? For all the information about grafts. Grafts is not much and it's basically almost the same thing as the fistulas. It's just different types of grafts, how the grafts are connected, how the grafts are made, the materials that are used to make the grafts also. And on page, I will say, you see page 102, the advantages and disadvantages of internal accesses. Learn all. There's the advantages and disadvantages for the AV fistula, AV graft, and the venous catheter. So any questions?
Not from me, miss.
Not so much.
Okay, I have just three things I want to mention also about grafts, right? Grafts are prone to stenosis. Stenosis is narrowing at the venous anastomosis, right? So the smooth intimal cells that line the patient's vein and the artery, it may be harmed by the high blood flow rates as blood returns to the arm. The body tries to repair the damage by growing new cells. And as more cells line the vessel, the diameter shrinks. Less blood can pass through the thrombosis, which is the blood clot, right? Less blood can pass through, and thrombosis, which is a blood clot, can occur. So grafts tend to need more tune-ups than fistulas to remove clots. Grafts also have a higher risk of infection because the graft material is foreign to the patient's body, right? And they have a shorter useful lifespan than fistulas, right, about an average of 2 years due to the fact that that is not the patient's blood vessel, right? Everybody with me on that?
Those are the disadvantages, yeah?
Yeah, that's some disadvantages of grafts. I just wanted to point out that.
Yeah, I have 4 written down from Dr. Alicia.
Nice. And within the book, the disadvantages and advantages is on page 102. Let me see if I could take out
Yes, miss. She was
Yeah, miss.
everybody
She
have
told
it.
us to learn those.
she told us to learn it.
Yes, they need syllabus. Because as I say, everything about AV fistula, everything about AV graft, and everything about catheters. Right? Ooh.
Miss Sir had mentioned in the previous, just before the previous exam, that he will be bringing in also not infection, disinfection and maintenance of the machines also in this exam. And
Right,
that,
for that disinfection and maintenance of the machines, right? Because you all went through that. Yes. And I was supposed to get in the last exam.
yeah,
You see that table? I just tell you see that table? Wait, have in the back of the paper. Right now,
yes,
I don't have the
the
handout in front.
peritoneal one and disinfection thing that handout you're talking about, Miss?
Huh?
The peritoneal dialysis and disinfection
Yes,
and
but yes, and I know it's in the back. I want you to read the disinfection or whatnot, but you see the table? Learn the table.
Okay, Miss.
Just leave me learn the table.
Miss, how you feel about the results this time?
I was real happy. I started jump. I was like, you see, I was just playing crazy and don't want to learn the work, boy.
No, miss, we wasn't so overwhelmed this time.
No, this exam was easy. And I tell everybody, I was like, this exam, the peritoneal dialysis exam is the most easiest exam that it have. And I said that it's even easier than exam number 1.
It was easy, but if we were bombarded by a lot of other things, it might have been different, eh?
Yes, I understand. I totally understand. I sent the advantages and the disadvantages in the group.
You know what I do wrong in the exam? The dwell time question.
Everybody, plenty people say they didn't do it correct, but it's how good people get correct. You forget to add in the
I didn't add, I
screen time.
subtracted.
What do you
Yeah.
mean you subtract?
Well, I didn't add in everything. I didn't add everything together, so I lost some points there, boy.
Well, at least you pass.
Yeah. If you see wine here yesterday.
All right, at least you pass, so that's a good thing.
Yeah, I want to keep passing through the US because I need all my marks.
Yeah, but these last set of exams doesn't be so tough, That's why I tell you all with this at the AV fistula and the AV graph, learn it, and the catheters, everything about catheters also. I don't want to flood your brains because it's already 8 o'clock, right? So that's why I didn't go through the catheter, the catheters, but do the different types of catheters. You all make questions and answer them to yourselves. If you all want, you could message me for any extra help. Anybody have any questions?
No, miss.
No, miss.
So everybody understand everything.
Yes, miss.
No, I don't see students logging out.
So far, yes, miss.
It's
Right.
straightforward so far, not so confusing as well, so far for me.
Yeah, I
Nice.
started get the hang of it today too. So
Nice. So you can practice doing into the essays and working. It have some students that point form works very well. So as we did the we said with the fistulas and with the graph, you start by talking about the creation of it and then the different types that there is. You understand? Then you go on to come the advantages and the disadvantages of these accesses.
but how much essays we could get on this exam? Like,
You just even though it's essays, it's everything about AV graph, AV fistula, and catheters.
okay.
So you need to know, right? You also need to you could need to know which access you will find more suitable for a certain type of patient. Things like this. You understand?
And how much rules the rule 6 have, really and truly?
I want to personally go back to the rules of sixes, right? Shania Maniram has it. She can send it for you guys. Cause I talking the truth and nothing but the truth. Honestly, I forgot all the rules of sixes. I know it's 6
Okay.
milliliters by 6 weeks by 6 some, but I know it had something with 6 something
But I'll send a picture
again.
of a T group chat.
Yeah,
Nice.
because Dr.
But I
Alicia
forgot
gave us
one of the
5.
sixes. It's either 3 or 4 rules of sixes that it has, but I want
It's
to go
5
through it with Dr. Mike. 5.
5 rules of sixes.
5 we got. We got 5, but I was watching a video and they had 6.
Oh.
That's why I say it's supposed to have 6 rules of sixes because it's 6 in everything. But I will go through it with Dr. Michael, right? You all will get it like by over the end of the weekend because Dr. Michael is not around, right? So, and I don't want to bother him. But Shania has some rules of sixes, and I will speak to Dr. Legion also. Oh yes, I can talk to Dr. Legion and ask her about it. The rules of sixes. To just be clear, I don't give information if I am not clear about it and if I don't feel comfortable about giving the information out. That's one thing about me. So I will clarify you on that, Ms. Kadira.
Thank you, Miss.
You're welcome. Okay, so we can wrap up now. Everybody understand? Anybody with any questions, message me.
Okay. Thank you for your time.
And please
Thank you, miss.
read up catheters for next week, Thursday. Right?
Okay.
And the advantages and disadvantages of everything also. So next week, Thursday, we will be going through that, the advantages and disadvantages of these accesses. And we will be going through catheters. The reason why I didn't go through catheters today is because catheters is a lot, because there are 3 different types of catheters, and also the perm cut from the temporary cuts and stuff like that. So I want that to just be a session by itself. I wanted either arteriovenous fistulas and arteriovenous grafts because they are both connected, right? And I didn't want you all to get confused, and I also wanted you all to know the difference between them and be able to make out the difference between them. That is why I did grafts and fistulas together, and I want to do catheter on a totally separate topic because it's a lot to take in with catheters also. So please read up about catheters. If you all want to write some essays and send, no problem. You know I like to read. So with that being said, everybody enjoy your night. To the people that message me, I will look into see I get your marks for you, please. don't feel discouraged. Okay, everyone.
Okay, Miss, thank you again.
You're welcome.
Thank you.
Everybody
Bye.
enjoy your night.
Thank you. Good night.
Good
Good
night.
night.
Everyone.